This conference will now be recorded.
Excuse me, sir. Sir, not audible, sir. We can't hear your voice.
Okay. Now it's audible?
Yes, sir.
Yes, sir.
Okay, I'll repeat again then. Okay, today we'll be discussing about paralytic squint. In paralytic squint, the etiologies are mainly by third, fourth, and sixth nerve. So these are the three cranial nerves which are involved in movement of the eyeball. So third nerve supplies all the muscles except the medial rectus, except the lateral rectus and superior oblique muscle. So lateral rectus is supplied by fourth nerve and sixth nerve supplies the superior oblique is supplied by the fourth nerve and sixth nerve supplies the lateral rectus. So third nerve mainly supplies all the recti muscles except lateral rectus and superior oblique. Fourth nerve supplies the superior oblique and sixth nerve supplies the lateral rectus. So what happens in a paralytic squint? When there is recti muscles are affected, obviously the movement of the eyeball is affected based on the action of the muscle. So lateral rectus muscle causes mainly abduction, that is abduction, that is lateral movement. Medial rectus mainly causes adduction, adduction, that is medial movement of the eyeball. And superior oblique, the main action is intorsion. So lateral rectus is supplied by sixth nerve. So when there is palsy of sixth nerve, the patient will have limited movement of lateral rectus, that is abduction. So what is the presenting feature of any nerve palsy? When the patient has a nerve palsy, the main complaint with which the patient comes is diplopia. So diplopia is what? Double vision. When a patient comes to you with diplopia, the first thing what you have to identify is whether the patient is having uniocular diplopia or binocular diplopia. Uniocular diplopia means when the patient is closing one eye, is he complaining of diplopia? Is he complaining of double vision with one eye, or is he complaining of double vision with both eyes open? In paralytic squint, it is binocular diplopia with which patient complains. So when the patient comes to you, you examine the patient and ask his complaints. What does he have? So he says, I have double vision, which is usually sudden in onset or very recent in onset. So what does happen once the patient has diplopia? When the patient has diplopia, the patient tries to compensate the diplopia or tries to reduce the diplopia by altering his head position. Suppose the patient is having horizontal diplopia. Horizontal diplopia means the image of the objects have moved horizontally away from one another. They see two images of a particular object which are horizontally separated, which is commonly seen in sixth nerve palsy. And to avoid that, what does the patient do? He does a face turn. Suppose he has a sixth nerve palsy which is on the left side of the eye, left sixth nerve palsy, then he will turn his face to left side to avoid diplopia. So similarly, fourth nerve palsy, what is the problem? Intorsion is affected. So because the eye is not intorting, he will tilt the head towards the opposite side. So when a patient comes with a particular head posture like face turn, head tilt, then when he enters into your OPD only, you have made the diagnosis. 50% of your workup is done there only. So usually a patient with nerve palsy comes with either face turn or head tilt, and his usual complaint is diplopia. So this is how usually a patient with paralytic squint presents, that is diplopia. Now coming to each nerve. So if you see the oculomotor now, it mainly arises from midbrain superior colliculus level. So superior colliculus level, oculomotor nucleus has many parts, or it has paired nucleus, unpaired nucleus, and single nucleus, like that. It has many nucleus. We will not go into all those things. All these nucleus supply different muscles. Mainly, what are the muscles these third nerve supplies? Levator palpebrae superioris, all the recti except medial, except lateral rectus, medial rectus, inferior rectus, superior rectus, inferior oblique, levator palpebrae superioris. So these are the muscles which mainly supplied by the third nerve. Apart from this, it also has pupilomotor fibers which supplies which are involved in constriction of the pupil, the efferent pathway of the pupillary constriction path of the light reflex. So when a patient with third nerve palsy comes to you, he presents with what features? He presents with the features of ptosis. Ptosis means drooping of the eyelid. Why there is drooping of the eyelid? Because there is loss of action of the levator palpebrae superioris. Levator means elevation. Superioris, levator palpebrae superioris means it does not help in elevation of the, it helps in elevation of the eyelid. So that is affected. So patient has ptosis. So medial rectus is affected. So adduction is lost. Inferior rectus is affected. So depression is lost. Superior rectus is rectus is affected. So elevation is lost, and inferior oblique is affected, so extortion is lost. So it has so many loss of actions because of third nerve palsy. Sometimes if pupilomotor fibers also are involved, pupil is dilated. So these are the features with which the third nerve palsy presents. So now let's see the anatomy, basic anatomy of the third nerve. So this is the nucleus of the third nerve. From there, it passes by the red nucleus, then superior cerebral, superior peduncles, and it passes between posterior cerebral artery and superior cerebellar artery, and then it passes along the posterior communicating artery, and it has a relationship to within the cavernous sinus also. Once it exits the cavernous sinus, it passes through the superior orbital fissure and then enters into the orbit. So this is the normal pathway. So lesion can be anywhere along the pathway. So depending on the presenting features of third nerve palsy with the associated features, whether the patient is having systemic features like tremors, contralateral hemiplegia, or any systemic features, such patients usually the lesion is at the level of the midbrain fasciculus or at the level of nucleus. If the patient is having third nerve palsy at the third nerve palsy with pupil involvement only, then you have to suspect the lesion to be somewhere along the posterior communicating artery. In this circle, what you are seeing is the circle of Willis. And if usually isolated only medial rectus palsy and only LPS palsy is very, very rare. If superior orbital fissure is involved, there also the third nerve palsy along with other nerves are also other nerve involvement is also seen. So through the superior orbital fissure, mainly the three motor nerves 3, 4, and 6 enter. If superior orbital fissure syndrome is there, or if cavernous sinus is completely involved, the nerves which pass through all these sinuses and the nerves which pass through the superior orbital fissure, all the associated nerves are also involved. So now we will stick only to the features of third nerve palsy. What happens in third nerve palsy? This is the location of pupillary fibers which lie dorsally and peripherally along the oculomotor nerve. So this is the, suppose these are the vasa vasorum which are present along the oculomotor nerve, and usually if there is an aneurysm or if there is a tumor which is pressing the dorsal fibers of the oculomotor nerve, the patient has involvement of pupil. If there is a extradural hematoma which is pressing the brain, then there is a tentorial herniation. This herniation also can press on the oculomotor fiber, or because of the prolapsing temporal lobe, the patient can have third nerve palsy on that particular side. If there is an aneurysm, that aneurysm along the posterior communicating artery, it can press on the oculomotor nerve and it can involve the pupil and it can lead to third nerve palsy. So any third nerve palsy, usually you look for two things. What is the status of the eye? Usually the eye is down and out. It is out because the lateral rectus is involved. The lateral rectus action is uninhibited. So lateral rectus, because of the uninhibited action of the lateral rectus, there is abduction. So the eye is out. Eye is down because of some action of the superior oblique, which is spared. So eye is down and out along with ptosis. And when you see such a case, you have to lift the lid and see whether the pupil is involved or not. If pupil is involved, it could be any of these cause like extradural hematoma or aneurysm. These are all emergencies, so you have to deal with it quickly. If pupil is not involved and pupil is spared, then it is usually medical causes like diabetes or hypertension, which usually recover. If the patient is having third nerve palsy, which is in which pupil is spared, then you have to see that then these patients have to be observed and their hypertension and diabetes has to be controlled. If the patient is having a third nerve palsy with where pupil is involved, it requires an emergency management trying to find what is the etiology, because either if it is an extradural hematoma or if it is an aneurysm, anything, both the conditions are very serious and require immediate management. Now, if you see the features, clinical features of third nerve palsy, you can see the eyelid is drooping here in right eye. That is called ptosis. There is mydriasis. There is mydriasis here. The pupil is well dilated here as compared to the left eye, and the eye is moved outwards because of the action of the lateral rectus. Adduction is lost, and elevation is lost, and depression is lost. You see this eye, depression is lost, and intorsion and attempted down gaze. So when the patient tries to look down, there is an intorsion and attempted down gaze, and there is normal abduction. So these are the primary features of third nerve palsy. Coming to sixth nerve palsy. In sixth nerve palsy, again briefly let's go through the anatomy. The sixth nerve palsy just is in front of the facial colliculus, facial colliculus of the fourth ventricle. From there, the sixth nerve enters, takes the path along with the internal carotid artery after passing through the along the pyramidal tracts, and from there it enters the Doralus canal, and then into the cavernous sinus. It has a relationship. Sorry, this is the basilar artery and this is the internal carotid artery, and from there and it enters into the superior orbital fissure and supplies the lateral rectus. So I'll repeat it again. From the facial colliculus, the sixth nerve nucleus passes along the pyramidal tracts and along the basilar artery. From there into the Doralus canal, from the Doralus canal along the internal carotid artery in the cavernous sinus, and from there into the superior orbital fissure, and then into the lateral rectus. So this main action is supply is lateral rectus. So how does these patients present? If you see here, because lateral rectus action is uninhibited, or there is no action of lateral rectus, the medial rectus is overacting and it leads to esotropia. So the right esotropia in primary position due to unopposed action of the right medial rectus. So this is how a patient with a right lateral rectus palsy presents. When you ask the patient to see on the right side or dextroversion, there is a limited movement of the right eye. But if you see the left eye has completely moved because the medial rectus is normally acting. So there is marked limitation of right abduction due to lateral rectus weakness. So these patients, to avoid diplopia, they have a face turn towards the action of the palsy. That is, for example, the patient has right lateral rectus palsy, then there is face turn towards that. So if you see, and this is an example of old right sixth nerve palsy. In primary case, it appears normal because this is after a period of time when sixth nerve palsy improves. This is how the patient appears. So straight in primary position due to partial recovery, and there is a limited right abduction on, and patient has horizontal diplopia. So if you see here, the eye has moved towards the nasal side. There is some adduction here, but there is no abduction action. But when the in levo version, when the patient is looking completely towards the left side, both eyes appear normal. So what are the causes of sixth nerve palsy or isolated sixth nerve palsy? Whenever there is an raised intracranial tension, because of that, this nerve passes through the petrous tip of the temporal bone. It presses on that and it leads to palsy. So a patient with sixth nerve palsy, first thing you have to rule out is whether the patient is having a raised intracranial tension. If the patient is having an acoustic neuroma along with sixth nerve, there are other nerves also which are involved, which has to be ruled out. So a patient with sixth nerve palsy, the main thing what you have to check is whether the patient is having acoustic neuroma or raised intracranial tension. So to rule out raised intracranial tension, you have to do a fundus examination and rule out papilledema in the case of sixth nerve palsy. If none of these are there, then it could be due to vascular causes like hypertension or diabetes, which needs to be controlled, and gradually this lateral rectus palsy improves. Now coming to fourth nerve or the trochlear nerve is the only cranial nerve which emerges dorsally. It crosses each other. It's a crossed cranial nerve because the fibers cross. There is a decussation and crosses on the opposite side. Say a right nucleus comes towards the left side, and left nucleus, the nerve comes to the right side, and it's a very long and slender nerve. So it passes through this. This is the posterior cerebral artery, and this is the superior cerebellar artery. You can see here, this is the oculomotor nerve, and this is the trochlear nerve, and all these pass through the cavernous sinus. From the cavernous sinus, they enter into the superior orbital fissure and then supply the respective muscles. If it is trochlear nerve, it supplies the superior oblique muscle. So this is in brief the anatomy of the fourth nerve. So what does happen when fourth nerve is involved? When fourth nerve is involved, there is an hyperdeviation in primary position. Now, what is hyperdeviation? Hyperdeviation means if the eye is deviated towards the nose, we call it as esotropia. If the eye is deviated outwards, we call it as exotropia. If the eye is moved upwards, we call it as hyper. If the eye has come downwards or moved downwards, it is called hypo. So what happens in fourth nerve palsy? There is a right hyperdeviation in primary position when left eye is fixating. You can see this eye is slightly moved up as compared to the left eye. So, and there is excyclotorsion, which is difficult to appreciate in the picture. And in what happens when the patient tries to look down? You can see the left eye. When the patient is trying to look down, left eye is normal, but in the right eye, the eye has not completely come downwards. So because of this, when the patient tries to look down, he's having vertical diplopia, or he has vertical diplopia. So usually superior oblique muscle is called the copying muscle. So when someone wants to copy somebody's what is his next candidate is writing, he will look down and out like that. So when superior oblique palsy is there, the eye which has superior oblique palsy, the depression is lost. If you see here, and when the patient looks in complete left gaze, the hyperdeviation increases. So these are some features of superior oblique palsy. We will not go into how to test which vertical muscles are involved, because it is not required for undergraduate level. Undergraduate level, what is required is in superior oblique palsy, what happens? There is an hyperdeviation of the eye. Why? Because the depression action of superior oblique muscle is affected. Superior oblique has three actions: intorsion, depression, and abduction. So when this is lost, when superior oblique palsy is present, the depression, because of the depression effect is lost, the patient has hyperdeviation. There is a loss of encyclotorsion, so patient has excyclotortion, and patient has vertical diplopia. And when the patient tries to look in extreme left gaze, for example, the patient is having right lateral right superior oblique palsy, and he is looking towards the extreme left, the hyper deviation increases. So if the patient has left superior oblique palsy, when he tries to look in extreme right, exactly in the opposite side, then there is increase in hyper deviation. So these are the basic primary features how to identify the superior oblique palsy: vertical diplopia, excyclotorsion, hyperdeviation, and in extreme cases the hyperdeviation increases. There is a test called PARC three-step test, which helps to identify which vertical muscle is involved or which vertical muscle is affected. We will not go into that because for undergraduate level this much is enough. Now coming to nerve palsies. Most of the neuropalsies, if it is due to vascular cause, the usually they recover in a period of 3 to 6 months. If not complete recovery, 70 to 80% recovery is present. Even if after 70 to even if after 3 to 6 months, if no recovery is present, then you can improve the strength of the muscle by doing some surgeries. So these are called as strengthening surgeries or anterior positioning surgeries. So what do you do? For example, if lateral rectus is affected, if patient is having lateral rectus palsy, you supplement the action of lateral rectus by transposing the superior rectus and inferior rectus close to the lateral rectus. So this is called as Jensen's procedure, where you augment the action of lateral rectus by bringing the superior rectus and inferior rectus close to the lateral rectus. In superior oblique palsy, you do a procedure called Harada-Ito procedure. So what is happening here in superior oblique palsy? The superior oblique muscle action is affected. So you are splitting the muscle and attaching it towards the lateral rectus muscle. So this is a procedure which is done for superior oblique palsy to improve the action of superior oblique palsy. So these are all transposing. These are all muscle transposing procedures or anterior positioning procedures. These are called. These are usually to strengthen the muscles, because there is a palsy. The muscle will never improve. So you take an active muscle and you bring it close to the muscle which has lost its action. So this is in brief about third, fourth, and sixth nerve palsy. Now I will just play some videos which will help you understand better the clinical features. These videos are available on YouTube also. You can just go and click that and you will get a better idea about what we have just spoken.
Cranial nerve 3, oculomotor nerve, the most important nerve as far as eye. Knock that out, knock out most of the eye muscles. In fact, you don't need to remember what muscles cranial nerve 3 innervates, just remember what it doesn't innervate. And it doesn't innervate the lateral rectus, because that's the abducens nerve, that's number 6. And it doesn't innervate that crazy superior oblique muscle that it's pulling. So everything innervates. It also innervates the levator muscle. The levator muscle is that muscle that's responsible for keeping the eyelid up. So if you have a cranial nerve palsy, what you'll see is that a little be droopy, you'll have some ptosis. The eye will be somewhat outwards because cranial nerve 6 is still pulling out. And it'll be somewhat downwards because cranial nerve 4, that superior oblique muscle, is kind of yanking the back of the eye so that the eye goes down. So you have an eye that's down and out. Down and out is cranial nerve 3. You got somatosis, down and out eye, that's a cranial nerve 3. And there's also pupil involvement sometimes. I'll go over that in a second. So what causes a cranial nerve 3 palsy? Probably the biggest cause of all the palsies is some vasculitic process, either from diabetes, hypertension. Basically, you have a mini stroke of one of these cranial nerves, and the nerves go out. For cranial nerve 3, you also need to think about aneurysm, and I'll talk about that pretty soon. This is a computer simulation with that right eye. It's somewhat down, somewhat out. It doesn't go up very well. It doesn't go medial very well. It goes down pretty good. It certainly goes out very well. You can see our pupils dilated as well. So down and out is the key. So horizontal, maybe a little more here. So moving on. So dilated as well. So down in.
See, there is a small mistake in this picture. The patient who has third nerve palsy will have drooping of the eyelid. You will have to lift this eyelid to examine this movement of the eye. What he's showing? You can see that there is a adduction loss and upward elevation is lost. The eye is usually down and out with pupil involvement.
Now is the key. So horizontal, maybe a little bit more fair. So moving on. So what is the importance of the pupil? Well, at this point, it may make more sense to look at the brainstem so we can understand how the cranial nerve 3 and really the other cranial nerves travel. Now, cranial nerve 3, the nucleus for it is up here in the midbrain. It's sort of under the superior colliculus. Comes forward through the, I guess it's the cerebral peduncle. It's been a little while since I looked at an atlas, but basically comes forward in the front part of the midbrain and travels towards the cavernous sinus before entering the back of the eye socket. Now, the cranial nerve 3 is somewhat special in the sense that it goes very close to the circle of Willis, particularly where the posterior communicating artery connects to the internal carotid. And that site, that junction of the posterior communicating and the internal, you can get aneurysms. Barry aneurysms are very common at this junction point. And if you have an aneurysm, it can push on this nerve and it can cause a third nerve palsy. Now you can imagine that the distinction between aneurysm or a tumor at this point versus just some type of mini stroke from diabetes or hypertension is a very big distinction that can't be missed. So if we think of our cranial nerve 3 here, it's traveling from the brain and it's going towards the eye. Deep inside all the cranial nerve, well, really any nerve, is a vasculature. Nerves need a blood supply too if they're going to survive. And you can imagine that the vasculature in nerves is usually pretty deep. It's deep inside that nerve. And if you have high blood pressure or diabetes and it hits that nerve and it knocks it out, well, it's going to hit it deep and it usually gives you pretty substantial findings. However, the parasympathetics are responsible for pupil constriction. So you see a bright light, parasympathetics kick in and it constricts your pupil. Those parasympathetics travel with the third nerve, and they have a tendency to run on the outside of the nerve. So they're very susceptible to compression. So if you have an aneurysm or a tumor pushing on that cranial nerve 3, then it very often will blow the pupil be involved. While diabetes or hypertension is deep inside the nerve, will sometimes spare the parasympathetics. So pupil involvement is crucial to see, to document if you have a third nerve palsy. So the moral of the story, pupil involvement is bad. And, realistically, if you have a third nerve palsy really of any sort in this day and age, it probably makes sense to image because it's
Now let's go to fourth nerve palsy. What happens?
finally the hardest cranial nerve is number 4. Cranial nerve 4 only innervates the superior oblique muscle. That's all it does. This nerve palsy is very subtle. That superior oblique muscle doesn't do a whole lot, but it does enough. And when it gets out, it has very complicated findings. This is a hard palsy to pick up. A lot of neurologists will miss this. A lot of ophthalmologists will miss this because it's not always obvious, and everyone seems to present a little bit different. Classically, if you have a right superior oblique palsy, you'll have that right eye is a little hypertrophic and it's pointing up a little. I'm sorry, I'll go back. It's pointing up a little bit, and also people tend to have a little bit of a head tilt in that direction, away from the lesion. So this is a right fourth nerve palsy. Tilt their head to the left, and the causes are manyfold. Unlike the other ones that are, have some pretty straightforward ones, really anything can cause cranial nerve 4 vasculitic, trauma, congenital tumors, and let me show you why. Cranial nerve 4 is up here under the, I guess it's near the inferior colliculus, basically pops out the back of the eye, wraps all the way around the brainstem before entering the cavernous sinus. This is a really long nerve. It's long, skinny, and it's very susceptible to damage. Basically, the nerve can pull out at its insertion in the back of the brain. You can imagine any type of tumor or a lesion anywhere along this course can hit this nerve. Really anything can cause cranial nerve 4 palsy. So what does it give you? Well, we've already gone over this a little bit. Basically, the functional origin of this nerve is up here at the trochlea, bridge of the nose, wraps around the eye, can cause a torsion extorsion problem. So if the eye can't intort well, it has a tendency to extort, and that's why they have the head tilt. It tilts so that it minimizes the double vision from that. It has more of an up-down motion problem as well. One of the ways I like to conceptualize what that superior oblique muscle does is if you pretend that your whole head is a giant eyeball and you wrap your arm up and around the back of your head such that the elbow is trochlea, or that pulley at the bridge of the nose, you can kind of understand how the eye should move if you pull. So basically, if you're looking, pretend this is your right eye, if you're looking towards your nose over here, then when you pull the back of your head goes down. So up-down motion. However, if you look off to the side, then pull, the head kind of twists like that. And that's more of that intorsion extorsion. So knowing that, we can look at this eye. Now I want you to watch that right eye very closely, the patient's right eye. This is a right forearm palsy. And it moves pretty well. To me, someone comes in with this is very hard to diagnose. This is obvious, but in real life, very hard. But if you watch that right eye, watch it, look over there, the eye goes up, and it comes back to normal. And it moves pretty well. To me.
So if you see that in extreme left gaze, there is hyperdeviation of the right eye. So that is one most important feature of superior oblique palsy.
This is very hard to diagnose. This is obvious, but in real life, very hard. But if you watch that right eye, watch it, look over there.
That is the hyperdeviation which you are seeing, extreme left gaze.
That right eye keeps shooting up every time it goes towards the nose, back to normal.
Whenever patient is asked to look extreme left, the right eye shoots up.
Finding with a forearm palsy, every time the patient looks to the other side over here, this eye has a tendency to shoot in an upwards motion, because normally the superior oblique would make you look down, but if it's out, the eye goes in an upward fashion. This is a pearl right here. So what kind of activities does this give the patient a problem with? We can imagine that when does the eye look inward towards the nose the most? It's with reading. You try to read a book and the eye's not getting down there all the way. They say, I'm seeing double vision. The letters are on top of each other. It's driving me nuts. Most of the time I can see just fine, but every time I try to read a book or walk downstairs, it gives me a lot of problems, and that's what a forearm palsy is. That's maybe one way you want to memorize what a forearm palsy does, is it gives them double vision when you try to read a book, and you can kind of conceptually think about it. So anyway, I won't.
So now let's go to the last nerve palsy, that is the sixth nerve palsy.
All right, cranial nerve 6, maybe a little bit less complicated. The sixth nerve only really controls the lateral rectus, which makes the
eye is gone into esotropia.
So if it's knocked out, you're going to have a cross eye. Causes, once again, diabetes, hypertension, those vasculitic things that give you a little stroke to the nerve. But you also need to think about intracranial pressure. Discuss that in a second. So how does it look? Now this is a right 6 palsy. Watch that right eye. It looks out to the side. It doesn't get out there all the way.
It does not move out because lateral rectus action is lost on the right side.
Every time I look to the right, because that right eye is not getting out of there, it's causing more crossing in that direction of gaze. When you see something like this, we know theoretically what a 6 nerve palsy ought to look like, but knowing what it should look like and actually looking at a real life patient sitting before you, it's not always obvious. It really isn't. I mean, yeah, it's obvious when we talk about it. You see it in the cartoon version, but it's not always obvious. So just document. You just write down which eyes don't get out, then you can sit down and say, what, that makes sense for a 6 nerve palsy. This drawing really serves one purpose, and that's one of the extra causes of a 6 nerve palsy is high intracranial pressure, or pseudotumor cerebri, or idiopathic intracranial hypertension, whatever you want to call it. But if you have high intracranial pressure, which is common, especially the fours, young women in their 40s or fertile, I guess the F's, 40, fertile, obese women tend to be a little bit more commonly get high intracranial pressure. But anyway, high pressure around the brain affects the 6th nerve. Here's a theory why. The 6th nerve is down here in the pons, basically pops out the bottom of the pons, runs up the floor of the cranial vault, runs near Dorello's canal before popping into the cavernous sinus. And one theory is that something about this turn right here, I didn't really draw it very well, but there's a almost 90-degree turn from this cranial nerve 6. Just have to go way up here, then turn suddenly. Maybe there's something about this turn here, this 90-degree angle, that's very susceptible to pressure. Maybe pressure pushes the brain around, who knows? But something about this turn is one theory why high pressure seems to hit cranial nerve 6. But you'll get a young person in who has double vision, and you'll find they have a bilateral cranial nerve 6 palsy. You look inside their eye, and they have some papilledema or some swelling of their optic nerves on both sides. You got to start thinking about high intracranial pressure. Send them off to the neurologist, get a spinal tap, get an opening pressure, find out what it is.
Okay. With this, I end my class. Thank you.